Endometriosis affects 1 in 10 women. An average woman in the United States will suffer from endometriosis and may not be diagnosed for 10 years. Today on A Woman's Outlook, I'm your host, Deb Hoch. I have with me Dr. Mupombwa. Welcome.
Thank you very much, Deb. I'm very excited to be here with you today.
Give us your background and your title.
So my title is a minimally invasive gynecology surgeon. And what that entails is that I had extra training after residence to focus on complex pelvic surgery.
Explain that.
So my fellowship was mostly focused on treating women with fibroids, women that came in with big fibro uterus, women that would want their fibers taken out or the uterus taken out would be able to do that through tiny incisions, thereby enabling them to be able to go home the same day. My focus is also on things like endometriosis, which we'll talk a lot more about, and also women that come in with large ovarian masses that if they went somewhere else, someone would end up doing a big incision, but if they came to us, they would end up going home with tiny incisions with better outcomes from the surgery.
Now, it's kind of scary to know the statistics. It's 1 in 10 women.
That is actually a really high number. The frustrating thing or the sad thing when it comes to endometriosis is that by the time a woman finds out that she probably needs to see a doctor or gynecologist for the symptoms, and by the time she gets diagnosed with endometriosis, that takes anywhere between 7 to 10 years. So you can imagine the frustration that a woman goes through before someone actually sits down and understands what's going on with her.
You know, you hear a lot of young people today being diagnosed, but is there an age range of those diagnosed with endometriosis?
I would say not really. I think it all depends on when they end up presenting. So you can see someone from the time they start their menstrual period, so maybe from age 12 to 13, and even some women in their 40s presenting with endometriosis. So it's just a wide range of ages.
Wow.
Yeah.
That's kind of scary, though, in today's world, for it to take that long to be diagnosed.
It is. And I think part of the reason, I feel like there are a lot of factors that contributed to that. One of the reasons is that we tend to downplay pelvic pain or pain with menstrual cycles. A lot of women are told that that's part of you becoming a woman. You should embrace the pain.
Oh, sure.
Which is not a good thing to say. And even, I feel like another thing that contributes is that when it comes to endometriosis, somehow there also ends up being a family history of endometriosis. So if you're someone who's born in a family where your sister had endometriosis, your mother had endometriosis, they tend to downplay having pain. And so in that kind of family, people tell you, that's okay, we've all gone through that, it's normal for you to have pain. And even in certain cultures, you're told having pain shows that you're now a woman. A little bit about myself. I'm originally from Zimbabwe, and I had a lot of friends in high school where they would miss school, they would miss classes, and every time would say, that's part of it, that's part of your menstrual cycles, you are supposed to have pain. And that's kind of part of the a thing that's lacking in the knowledge in our community, that it's not okay for you to have pain with your menstrual cycles. It's not okay for you to miss school. It's not okay for you to miss work because of the pain.
You know, you spoke about, hereditary. Mm-hmm. But is it hereditary or is it developed?
So that's the big question. We don't know. So the thing with endometriosis, and I think that's part of the reason why there's not a lot of information out there, is that there is a lot of research that is lacking. There's a lot that we still don't know about endometriosis. And so we do know that the family history does put you at a risk of having endometriosis, but we don't know if there's a gene associated with that. And we don't really know if it's something you're born with or something that you end up developing later on in life.
Clarify, what is endometriosis?
So endometriosis, the way that I explain to my patients is that when you look at your uterus, the inner lining of the uterus, which is called the endometrium, has tissue. And in someone that doesn't have endometriosis, you're only supposed to find that tissue on that inner lining. But for some reason with endometriosis, that tissue can go into the muscle layer, it can go into the ovaries, forming things, ovarian cysts called endometriomas. It can go into the pelvis, and then in some situations can go to the bowel, can go to the bladder, causing
Wow.
symptoms related to urination, bowel movements. And in some rare situations, I've had a couple of patients where the endometriosis goes to the lungs, and people
Wow.
have, every time they have their menstrual cycles, they're coughing up blood, they're having chest pain, and very rare situations, sometimes it can go into the brain. So it can pretty much go anywhere, but most of the time it's usually in the pelvis, and you end up having symptoms with where it's located.
That's pretty scary, though.
That is really scary.
I mean, for the fact that it can travel beyond that. And I just thought it was contained in that one area. But to realize that it may take 7 to 10 years to diagnose, you don't know where.
And all that time, you're suffering from the symptoms. And you see these women presenting so many times to the emergency room with pelvic pain. Some people are having chest pain, and everyone is just telling them it's in your head, and they actually have something else going on.
Here's the thing. What are the symptoms?
So the symptoms can range from asymptomatic. So some people, when you go in, let's say if you're operating, you go into the abdomen, they might have extensive endometriosis, but no symptoms at all. And then the symptoms that people actually have, people that have symptomatic endometriosis, usually it's pain with menstrual cycles. But beyond that, some people can even have pain with sex. So that's something that some patients, if they go to their physician or anyone and tell them I'm having pain with sex, people might downplay that and say that, oh, it's okay for you to be having that, but that could also be from endometriosis. Some people can have pain with urination. They can have blood in their stool. They can have constipation. They can have bloody stools. Like, it's all a range of symptoms that they can have from that. Another thing that endometriosis can do is that it can contribute to infertility. It might not necessarily make it difficult for you to get pregnant, but it might make it difficult for you to get pregnant. Endometriosis can cause scarring of your tubes, of your ovaries, which might make it hard for you to get pregnant. So it's all a range of symptoms. And again, if the endometriosis is like up in your lungs, then you have symptoms of like coughing up blood.
You know, when you go to an ER or you're having some of these symptoms, you know, how often is someone misdiagnosed?
So I would say it's a high number. Like a lot of women are misdiagnosed. Most of the time they're just told it's just pain, it will eventually go away, or it's something that's in your head. But a lot of women are misdiagnosed when they go to the emergency room.
As time goes by and you're continually told that, you don't end up going to get checked out if you're still repeatedly having any of those symptoms.
Exactly.
Or getting more of the symptoms, I have to say.
Exactly.
What do you feel I mean, let's say they go, but how would they be tested for endometriosis?
So unfortunately, there is no blood test or urine test that you can do and say that you have endometriosis.
Wow.
And even sometimes when you get imaging, if some women with endometriosis, if you get a pelvic ultrasound, it might look normal even though they actually do have endometriosis. So in terms of like a diagnostic test, we're still like working on that. There still is a lot of room for research for that. The only way that you can diagnose someone with endometriosis is if you do surgery, going in laparoscopic surgery, getting tissue sample, and then sending that for pathology. And that's the only way it can be confirmed that you have endometriosis.
So a person who has some of these symptoms and find out from a primary or gynecologist or something, you know, that it's happening repeatedly, should they suggest something, or should they venture out to search for a specialist of a certain type to find out what really is causing these symptoms?
So I think the biggest thing for most women is finding someone that's going to actually sit down and understand what they're going through. So I would say for anyone who's having those symptoms, they should probably look into seeing a specialist and seeing if this might be related to endometriosis. If it's not, there are other things that contribute to chronic pelvic pain. And with most centers, like at Care New England, we have a facility of whereby if it's not really endometriosis, we direct you to the right people that can be able to look into other causes for chronic pelvic pain. So it could be something to do with your bowels, and we work closely with the bowel doctors. It could be something to do with your bladder. We work very closely with the bladder doctors. We have pelvic floor physical therapists that can also we can be able to refer patients to. So going to a place that has a multidisciplinary approach is something that I would recommend people to do. That way they can be able to direct you to the right people if it's not necessarily endometriosis.
Now, if they've made an appointment, what are the first things they should either bring with them or notify or know of before they come to the first appointment?
I think the biggest thing is trying to, if you can look into your qualifications, the qualifications for the person that you're going to see, I would recommend if you can go to someone who has high volume surgery for endometriosis. And I know some providers might get offended by this, but one of the things you should be asking when you go to your first visit, ask them how many procedures do they do for endometriosis. Right. Ask them how do they treat the endometriosis, because there's so many different approaches in terms of how you can do the surgery. And then also ask them if they don't find endometriosis, what's the follow-up for you? So looking into that is like the first thing, to really look into the background of the person that you're going to be seeing.
I think that's in anything that you should read reviews, how long they've been doing it, what their research has been, because it's important. They're going to be taking care of you.
Absolutely. And then if you're someone who's had some workup done, also come with those documents, like if you've had any ultrasounds, if you had any surgeries, just come with that information to the first appointment.
What is the care of endometriosis?
It really depends on who's taking care of you. If you talk to a lot of providers, like the first line of treatment is, let's say if I have someone that comes to see me with pelvic pain and I'm suspicious that they might have endometriosis, the first thing is to start off with medication. And then based on how they do with medication, eventually go to surgery. That being said, there's some people that if someone comes in has a really high suspicion for endometriosis, the first thing they might do is to do surgery first, and then eventually put them on hormonal medication. So it pretty much ends up being a combination of both things, both surgery, like to excise, to take out the endometriosis tissue, and then medication to suppress and calm down, like what the endometriosis tissue is excreting.
Is it cured?
Unfortunately, not really. So my goal when I talk to patients is that I want to improve your quality of life. Right. So my goal is that when I start seeing you, when we start doing treatments, by the time we get to a certain point, you're a different person. Like I want my patients to be able to go back to work, to be able to even just sit down, watch TV, relax with your family. That's my goal. Some patients, if it's just endometriosis that's focused on the uterus, if you take out the uterus, then they're healed. But if you have patients that have endometriosis in certain places that we cannot be able to see visually with our eyes, those people might need some medication afterwards, which eventually will improve their quality of life.
Now, if they have been diagnosed with endometriosis and it has gone to other parts of the body, how are you able to contain that?
So two things. If it's in a place that you're able to take out the endometriosis, then you take out the endometriosis tissue. And then by putting them on medication, so then that might suppress the effects from the endometriosis itself. Okay. People are still trying to come up. So the medication itself is only meant to kind of like quiet down the harsh environment from the endometriosis. But it doesn't necessarily stop things from progressing, and it doesn't necessarily reverse the endometriosis. So some people are trying to look into medication that might reverse the effects from endometriosis.
Have they found anything that causes the flare-ups that they may have? Not in today, huh?
Not today. Still trying to figure that out. Some people do postulate that your diet could contribute to that. So even at Care New England, we pair our patients with like a nutritionist that try to adjust their diet and see if that might help with like another flare-up for endometriosis. But I would say right now the main thing is trying hormonal medication. That might be the main thing to prevent a flare-up in the future.
Why don't we tell our viewers a little bit about you, where you started, how you became interested?
How far back do you want me to go?
You can go as far back as you'd like, because it's interesting, especially if you're seeking a doctor. You want to know about them.
So I was born and raised in Zimbabwe. I grew up in a family with two brothers. I'm a middle child, and so I have middle child syndrome, which probably explains my personality and how I always felt like I needed to become a surgeon. And so in my last year of high school, that's when I decided to apply to the US. I didn't even know anything about the SATs. And the only reason why I came across that is that there's a lady, her name is Rebecca Mano. She is American, and then she got married to a Zimbabwean, and they both moved back to Zimbabwe. And so she used to work for the Zimbabwe education system. The United States education system, which helps the Zimbabwean students to apply to the US. And during that time, she noted that a lot of the students that were applying to the US were students that came from rich background. So she then started a program called the United States Students Achievers Programs, which recruits students in their last year of high school that come from economically disadvantaged backgrounds, helps them with the application process, with the SAT fees, and then eventually you get a scholarship to go to the US. And so I was fortunate to get recruited into that program. And so I always like to tell people this story. So I ended up going to the University of Pennsylvania in Philadelphia. And people ask me, how did you choose this? So my sister and I, we were sitting down and going through the college catalog and looked at the name Pennsylvania, like, oh, this is such a fancy name. Let's apply to Penn. And so that's how I applied to Penn. So I came to the US, went to University of Pennsylvania for college, and then went to Harvard Medical School for medicine. Did my residence at Beth Israel in Boston. And then it was during that time, I actually did a rotation because I have a strong interest in global health, obviously given my background. I went to Botswana where I did a rotation for 1 month, and during that time realized the importance of global surgery. I feel people focus on AIDS, HIV/AIDS, maternal health, which is all important, but one of the things we tend to neglect in low-resource settings is global surgery. And so that's when I decided to do a fellowship in minimally invasive surgery, because I do believe that if you're able to provide minimally invasive surgery in low-resource settings, those women are able to go back to work quickly, and most of those women are the breadwinners. They have less complications, less infections, and then their pain is much better controlled. And so that's how I got interested in minimally invasive surgery. And in particular, also got drawn to things like fibroids and also endometriosis. And so that kind of explains why I did what I'm doing. Yeah.
Quite extensive. Now, do you find that endometriosis, we talk about the women in the United States, but how about outside the United States?
I feel outside the United States, it's kind of like also in the US, it's underdiagnosed, and it's even worse outside especially in low resource settings where you're just told to deal with it. It still also does happen here in the US, but it's not, I am pretty sure a lot of women have that, but have not been diagnosed or have not been able to get access to care for that.
That's a shame. I mean, because even here in the United States, women all over the world are told, suck it up, and move on. Yeah. And I can remember years and years of, when young women have menstrual, you just have to get on with life. This is the pain. And some have really excruciating pain where it incapacitates them to where they're bedridden for days. And sometimes you think to yourself, really, are you know, that bad? But as you say, yeah.
Exactly, that is the thing. I remember one time when I was a teenager and one of my cousins was visiting us. She had really bad cramps. And my mom the whole time was like, she's such a weakling. Why is she lying down? She should be doing household chores. And I also supported her. I was like, yeah, she's being lazy. I thought she was trying to get out of doing household chores. But now that I think of it, it's, yeah.
Could have.
She was in pain. Yeah.
Now, as you say, some women, it takes most of the time 7 to 10 years to be diagnosed. Have you found where it hasn't been diagnosed, but when it is, how bad is that?
So the unfortunate thing with endometriosis is that the amount of endometriosis you have does not correlate to the pain that you have. So,
oh, wow.
Yeah. So you can have someone who has extensive endometriosis and no pain at all. And then you can have someone who has extensive pain, has seen so many providers, has had to miss work. You go in and you just see a tiny spot of endometriosis, which really tells us that there's still a lot more that we need to understand about the disease. So the level of pain is not necessarily correlated to the amount of endometriosis you have.
Because it's scary if you have an enormous amount within you and you have no symptoms.
Yeah.
Because it's still growing. It's still moving throughout the body and you don't even know it.
Yeah. And I would say in those women, as long as it's not causing any harm, then probably you should be fine. But you also get worried, like, what if it gets worse? And then it starts affecting organs like the bowel or the bladder. What's the next step? Yeah.
What would you like our viewers to know out there about endometriosis or to be aware of?
So I would say that endometriosis is a real thing. So if you know of anyone or if you yourself have experienced any symptom like pain with your periods that is debilitating, that you've had to miss work, that is even affected your productivity at work, that's like because you're not really able to get things like promotions, or if you know of anyone who's going through something that seems like is endometriosis, I think it is worth it for you to either talk initially to a primary care doctor, or you can even just self-refer yourself to someone who is focused on endometriosis care. And for people that have endometriosis, even though I say that there is not like 100% cure, but we do have ways to make you feel better. Like, I have had a lot of patients after surgery that come back and they tell me, I'm a different person.
Good.
My kids thought I was depressed, because it can also cause you to have depression and anxiety. And I had one patient who, when I saw, she never smiled. I always thought like she was unhappy because she was in so much pain. But after the surgery, she was a whole different person. She was making jokes. So I say to the caveat that you might not be 100% free from pain, but you'll be at a much, much, much better place if you're able to get yourself connected with someone who focuses on endometriosis.
With all the education that you've had, the extensive amount of work and getting here, what do you do for relaxation?
A lot of things. So
I don't know where you'd find the time at this point, but
I watch an insane amount of TV. I think if I didn't watch the amount of TV that I watched, I would probably be more productive. I binge watch a lot of TV shows on Netflix. I also like to cook. So cooking to me is very relaxing. I like to explore with different recipes. I have a 4-year-old son. I like to spend time with my son and husband. Like, we go to the park, we go to the beach. And I think because I'm a surgeon, I always like to do stuff with my hands. So I like to knit. I sign up for different projects to just be able to like last month I was learning how to basket weave. So it's I always want to do something with my hands. Yeah.
Where do you find the time? I mean, being a mom with a 4-year-old, I know that's got to be busy.
That is you find time. It could be when he goes to sleep. It might compromise the amount of sleep that I have, but you find time.
Now, if someone's out there listening to this and either themselves or someone that they know have these symptoms, or that they have found where they've gone repeatedly to the doctor, to the ER, and it's a constant, how do they contact you?
So we will post our contact information, but right now I actually work at Women and Infants Hospital in Providence, Rhode Island. We have a department we're still working on growing our department, but 2 fellowship-trained minimally invasive gynecologic surgeons. And if they can get in touch with us, you can either be referred to us by your provider, by your OB/GYN, or you can do a self-referral. We're open to any of those ways.
I think it's important for people out there to recognize they don't have to be in this sort of pain ongoing.
Absolutely. And it doesn't have to be you having had to go to the ED many times or having had a workup. If you feel like something is wrong with the pain you're having, feel free to do a self-referral. We'll be happy to see you and starting from scratch. Like, we see patients in all walks of their endometriosis workup, like someone who's just initially presenting, someone who's like still in the workup process, and someone already has endometriosis. So any stage, we're welcome to see you for that.
You know, I've run across young people, middle-aged people, my age, and they've said, oh, we've had that, you know, and we've had this test and it's negative, and we've had every test there is, or a CAT scan, and it shows absolutely nothing. And then they begin to feel, you know what, there's no sense in complaining. I'm not even going to go again because it's not worth the time of being there.
Yeah.
What do you say to those people?
I say it's not okay for you to be in pain. We might not be able to, it might not be endometriosis, but like I said, we have pelvic floor physical therapists that might be able to help you. It might be something to do with your bowels, something to do with your bladder. We'll refer you to the right people so that at least you're not just suffering in pain. Yeah.
Well, I thank you so much for being here today, and to our viewers. You know, anyone out there, just one person, you have those symptoms or you have that ongoing pain, please make sure you get it checked out, because it's important. Life isn't about pain. But thank you so much for being with me here today. And we will post that information for contact with you. And good luck.
Thank you. Thank you. Thank you, everyone.
Thank you for viewing A Woman's Outlook. We'll see you the next time.